I think the number one risk factor of frequent headaches is frequent headaches. And when you're having them all the time, the brain just knows how to make the headaches. And as the headaches get spaced out, then it's harder for the brain to remember how to make a headache. I think as a clinician, we have to ask the question, what's making this person more vulnerable, and then try to address that. I like to start almost everyone on a couple of supplements like magnesium and coenzyme Q10. Principally, if we get back to that understanding of the sensitive brain that doesn't like change, another word for change is stress, and stress is anything that acts on you to provoke a response. Well, what are drugs? A change. And so very often people with migraine don't tolerate normal starting doses of medications. So I find that if I start with a couple of supplements, then I can add a preventive pharmacological medication in there, and I start them on 3 preventives at once, and that increases my chance of getting a better response sooner and get the patient buying because, hey, I'm seeing a difference. I am sleeping better at night. This stuff works. It helps. I don't I try to be as precise in my language as possible. And I'll have patients come in and tell me, I hate taking pills. I says, that's not really a helpful attitude. And how you need to say that is, I don't like taking pills unnecessarily. I don't like taking pills inappropriately. Because it was a wonderful placebo study done that pointed out that if a patient tells himself what the medication is going to do for them, it's more effective. And so I think if that's true, if positive feelings about a therapy improves a response, I think the converse is also true. Negative feelings about a therapy inhibit the response. So if you can give someone the most appropriate therapy in the world, if they don't want to do it, if they don't get the buy-in, you're not going to get the response because they could even be better and still think that they're worse. It's why are you feeling bad about it? Let's just say with the tricyclic, and they're saying, I don't want to be on an antidepressant. I don't feel I'm depressed. I don't want to be labeled as that. And it says, well, okay, that's not why I'm giving it to you. And that's where education could be. It's the same way as a younger patient that I'm giving an anti-hypertensive medication to. You don't have high blood pressure. You have this condition, and it's an off-label use, and try to explain that to them. Like probably one of the more dramatic medications that I'll use for migraine rescue is olanzapine, which is an antipsychotic medicine when taken daily, is principally for schizophrenia and refractory depression. But I tell my patients that I give that medicine to, it's for migraine rescue for you. You're not taking it every day. You're taking it once, twice a month for that headache that you'd otherwise go to the emergency department for. And I tell them it's for schizophrenia. So that way when they go and the pharmacist looks at it and it says, oh, well, they're only getting 4 pills, and it says on there for migraine rescue. So that way, if they understand the purpose of it and what we can expect as a benefit from it, I think they're more likely to be adherent to the therapy.